Hey everybody, it's Dr. Dave, Psychiatry, here reminding you that if medication helps you, that makes it a medical problem, not a mental problem. Thanks for coming to the YouTube channel today. Today we're talking about something that must happen pretty frequently because it happened last week, which made me think I should make this video, and then it happened this morning. So I jumped in the studio before lunch just to talk about this a little bit. And the question is, when someone says, hey doc, I can't concentrate, and they've been to the University of the Internet and they've read all about attention deficit disorder, which is can't concentrate, can't focus, can't pay attention. And they basically come to me expecting that I'm going to treat them for ADD and therefore expecting that I'm going to treat them with the norepinephrine booster. So if you haven't watched the videos on that, there's a video I did recently on Adderall. The point being that there is a really clear pathway to treating norepinephrine shortage with some medicines, but you don't always have norepinephrine shortage causing the picture of difficulty concentrating. So today we're really talking about the question of, in my mind, when you come to me, do you have ADD or do you have GAD? So do you have attention deficit disorder or you have generalized anxiety disorder? That's the thumbnail. And the thumbnail picture, the cartoon that you see on the YouTube channel, those are words, and I think if you study this channel a little bit, you understand that I don't really like diagnoses very well. I mean, we have to use them, but a particular diagnosis can be caused by multiple different chemical problems. So as a brain chemistry specialist, my job is to figure out what the chemicals are that are causing the problem. So today we're talking about when people can't concentrate, is it because they're not making enough norepinephrine? In other words, if the norepinephrine level should be here, but it's here, is that the problem, low NE? Or is the problem excess dopamine, too much dopamine, excess DA? If your dopamine should be here and it's not, it should be here and it's up here, that's a problem. So what do those pictures look like and how do we sort that out? Well, classically, low norepinephrine is responsible for the picture of can't concentrate, can't focus, can't pay attention, can't get things done, lots of stops and starts, loses things. And the medicines that we use to boost norepinephrine, like Ritalin or Adderall or Strattera or Wellbutrin, these are medicines that boost that chemical, and that's a good idea many times. But when you meet somebody for the first time you don't know, because the other side of the picture is you could be making too much dopamine. Dopamine being the thinking chemical, think too much, worry too much, can't shut your mind off. And many times people that have been diagnosed with attention deficit disorder that come to me that either have not had treatment or have been treated and had bad results with the norepinephrine boosters, well, they get better with the dopamine suppressors. They get better with medicines that push down dopamine to help them reduce that. So that's medicines like perfenazine, which is Trilofan, Zyprexa, Latuda, Geodon, sometimes Seroquel or Risperdal, the medicines that push down dopamine, which in many cases have been called and are called antipsychotic medicine. But if you don't have psychotic symptoms, we don't call them antipsychotic in this office. If you don't have psychotic symptoms, I simply call them dopamine suppressors. Now, we're using those off-label because they're not officially approved for conditions like attention deficit disorder. But the point there is that generalized anxiety disorder often mimics ADHD, and ADHD often mimics GAD. How do we decide what we're going to do first? Because the troubleshooting method is do something and see what happens. Do the first thing, see what result you get. If we start off with a norepinephrine booster and it doesn't go well, maybe they didn't have a norepinephrine shortage at all. So if you give somebody who's got a norepinephrine normal condition, you give them a booster, well, it goes abnormally high, and that causes the picture of jittery, jumpy, nervous, sweaty, jumping out of your skin. We talked about that before. If we start with a person that we think has dopamine excess and we give them a dopamine reducer, well, if they're here and we give them a dopamine reducer, they feel better. But if we give them a dopamine reducer and they're here, then they feel worse. So if we push their dopamine too low, then they complain of things like I felt dumb, I felt stupid, I felt not myself, I felt like I couldn't concentrate, couldn't get anything done. I was actually much, much worse with the medicine that reduces dopamine. So those are the clues. And you know that after you've done the trial. The question really happens when you meet a new person like I met this morning. How do we know the difference? How do we know where to start? One of the basic cut points is that when people say that their mind is very, very busy, think too much, worry too much. The reason that they can't concentrate is because they're thinking so many things. They might say to you, I've got ADD, my mind is all over the place. I'm obsessing about things I shouldn't obsess about. Yeah, that's my ADD, I think too much. Well, think too much ADD is very often dopamine excess. And so it's very common that when I see that picture, I'm going to encourage somebody to take a dopamine suppressor to push their dopamine level down as the first move. If we're right, we're right. If we're wrong, we're wrong. We read the results of the experiment and do the next thing. On the other hand, people that have sort of a quiet mind, they're sort of blank. They don't think too much. In fact, they think too little. They're sort of what you call spaced out. Can't sort of put things together very quickly. A lot of times associated with low energy as opposed to the high energy that you see sometimes with dopamine excess. Those patients often benefit from norepinephrine boosters. So that's the group of medicines that we talk about all the time. Ritalin, Adderall, Wellbutrin, Strattera, norepinephrine boosters. This morning, what did I do? The gentleman who sat across from me, I said, okay, which picture is more like you? Are you the busy mind or are you the quiet mind? And he actually said to me, a couple of months ago, I was sort of the busy mind. And today I feel like I'm more the quiet mind. So we started with the medicine to boost norepinephrine. The medicine we used doesn't matter. It was Ritalin. But the point is that we use something to boost his norepinephrine as opposed to something to bring down his dopamine. Now, he left today with a prescription. He's going to come back and tell me what happened, and I'm going to get a result. He's going to get a result too. Obviously, if he doesn't do well on the norepinephrine booster, that's going to be a clue. If he does well with a norepinephrine booster, we'll try to build on that success. The point that I make continually on this channel is that if you have medical symptoms and you need medical treatment for one of these chemical disorders, there is no blood test for this particular medical disorder. That's what makes this so much harder than treating diabetes or blood pressure, where we have actual numbers that we use. You know, thyroid, if your thyroid's off, we give you thyroid medication and then we measure your thyroid. There's none of that in my world. In my world, it only gets better by troubleshooting the problem. If you're a patient, you hope that your doctor is doing this. If you're a prescription writer, I encourage you to adopt the process. Study the videos, study the troubleshooting video, because this is really how we help people. We don't help people by just saying, here's some medicine, hope you feel better. We help people by saying, okay, let's have an idea, let's do something, test the idea, see what happens. That's what I'm going to do with the fellow I saw this morning. That's what I do with all the other people in my office. But today's patient really illustrates the question that is pretty frequent in my office, actually. Should this person be diagnosed with generalized anxiety disorder or attention deficit disorder? And based on those ideas, those pictures of symptoms, well, what is our chemical deficit really? Do they really have low NE? Do they really have excess DA? And once you do the experiment, you get an answer. All right. So I hope that's helpful to you. It's certainly interesting for me to talk about because I want to see what happens with this fellow that I saw this morning. And I hope that I'm helping him, and I hope I'm helping you with these videos. So I'm Dr. Dave, Psychiatry. Thanks for coming to see me today.